Hi, I'm Dr. Christopher DuCoin. I'm an esophageal surgeon at the University of South Florida, professor of surgery, vice chair of surgery, chief division of GI and general surgery. I want to thank the moderators for inviting me to speak, and I'm implicitly sorry that I can't be there in person to do this. We're going to talk today about the surgical treatment of gastroesophageal junction cancer, adenocarcinoma of your GE junction. I will review some other material on squamous cell just so we're all kind of on the same page. I am a robotic surgeon through and through. I work with both Intuitive, Johnson & Johnson, and Medtronic, as they are the robotic platforms currently in the United States of America. Okay, so the anatomy of the esophagus is extremely complex, and it makes the surgery a little tricky, but we have to know that there's three different areas in blood supply: the upper esophagus, mid-thoracic, and distal. The distal, right, the left gastric artery is going to be our blood supply. We're going to take every single case and ensure good lymphatic resection around that. The venous drainage, both systemic and portal, the azygous system critical here. The distal portion does go to the liver. Remember the portal venous drainage, and then the lymphatic drainage is complex. Cisterna chyli and the thoracic duct intimately involved with the esophagus. So must know anatomy for a complex operation. So it's either just a food tube connecting your mouth to your stomach, or it's one of the most fascinating, complex organs in the human body. Transition zone is the way I look at it. Skeletal muscle to smooth, squamous cells to columnar. You're changing your autonomic nervous system. It's really this kind of beautiful, beautiful part of the human anatomy, and very complex. Again, as you need to know both neck anatomy, thoracic, and abdominal. All right. So what happens when things start to go wrong at the G junction? So those cells, those squamous cells, are going to change. You're going to notice esophagitis and LA grade A, B, C, or D, or biopsies are going to show you. Is it Barrett's or something along those lines? I think you got a wonderful lecture earlier on different tumor markers. But we know this progression of disease from squamous to Barrett's to low and high grade dysplasia to eventually to cancer. And what's it linked with? GERD and obesity. We know as obesity goes up, your BMI, so does GERD. Great article in New England Journal of Medicine that showed that. And our warning signs: GERD coupled with unintentional weight loss or dysphagia, difficulty swallowing. We need to put our red flags up. Could something else be going on? Is this cancer? All right. How is it broken down? So Seward classification, type 1 and 2, definitely esophageal cancer. Type 2 really are GE junction tumor, which we're going to talk about. And type 3 is really now looked at as a gastric cancer. Epidemiology, you need to know this stuff. So about 600,000 cases worldwide. Deaths are almost as common as the number of cases, which is bad when your incidence equals your mortality. It's different though around the world. So Asia, Africa, more squamous cell. That's going to be your upper mid esophageal tumors, while your Western world, the United States, has more your distal tumors or adenocarcinoma at the G junction, which we'll talk about. And 2040, probably about a predicted million new cases. So looking at just United States data for a second, about 17,000 new cases a year, about 16,000 deaths a year. It's the 7th most common cause of death, cancer related in the United States in men. But that's only 1% of all tumors. So not a good tumor to get. Incidence is flip-flopped in the United States and Western world. So used to be squamous cell, or again related more to lifestyle, alcohol, smoking, while adenocarcinoma is now spiking quite high, and one of the fastest growing incidence of disease tumors in the United States. Differential here breakdown we kind of discussed: adenocarcinoma distal, squamous middle, upper, squamous lifestyle, smoking, alcohol, adeno, Barrett's, GERD, obesity, but both predominantly in men, either 3-to-1 or 7-to-1 ratio. Prognosis is not good. About 50% of people who walk into your clinic are going to have metastatic disease that's non-curable. About 30 to 40%, this is our trimodal treatment. This is the areas that have local regional disease. This will require some sort of chemotherapy, radiation, plus surgery, and a very select few are going to have early disease. That's that T1A disease, where we can maybe treat it with endoscopic management or resection alone. So staging, we're going to look at the big differentiator in staging is going to be, is it a T1A or T1B. T1A disease will have less than single-digit lymph node involvement, while T1B double-digit. You're into the somewhere between 15 and 20% chance of lymph nodes. So critical to delineate those two. How do we do that? Endoscopic ultrasound, part of every single workup, in my opinion, unless you know there's metastatic disease. And we want to see where is that, what's the depth of the tumor into the wall of the esophagus, and are there lymph nodes involved? Critical to know your T and N staging. Next up is metastatic disease. PET scan is great for this. So this will let you know, is there metastatic disease throughout the body, liver and lungs being the most predominant. And our staging is going to be critical to know our what to discuss with our patients and our ultimate outcome. And you notice the earlier it's picked up, you see those red lines, stage 1A and B, much different survival curves versus your blue lines down there, stage 3, A, B, and C. So treatment guidelines. We're going to focus more of the talk today on this area, trimodal treatment or perioperative treatment coupled with surgery. And you can see, is it chemotherapy and radiation or chemotherapy alone? And been some recent updates in that area. One of the most classic studies, the CROSS trial, published in Lancet in 2015, so just about 10 years ago, really showed that trimodal treatment, chemotherapy plus radiation, followed by surgery superior to surgery alone. What you notice there, squamous cells, massive gains. So 75-month survival versus 12-month survival when you're using chemotherapy plus radiation, and still great survival with adenocarcinoma, but not quite as much. 18-month surgery alone versus 30-month with chemotherapy plus radiation. Again, toxicity was an issue. 13% had grade 3 toxicity, but massive win for the treatment of cancer, esophageal cancer, with the CROSS trial. Next up was the published in Lancet 2019 FLOT4, and this is specifically looking at what we're talking about today. So adenocarcinoma, distal esophagus, and the FLOT regimen alone, so chemotherapy alone versus standard chemotherapy. And what we did was 4 cycles preoperatively, separated by 2 weeks, followed by 4 postoperative cycles, FLOT 50-month survival versus standard chemotherapy alone, 35 months. Notably, a higher rate of tumor regression and downstaging. However, FLOT is a tough chemotherapy agent. 20% required dose modification preoperatively, so not everyone could tolerate this. Big news, New England Journal of Medicine 2025. This is cross protocol compared to FLOT. And what we saw were massive gains again, overall survival and progression-free survival, FLOT favoring FLOT over cross protocol. And this is really where we standardized and changed our chemotherapy treatment preoperatively from for adenocarcinoma in particular, from chemotherapy plus radiation to chemotherapy alone. All right, pivoting to surgery. So the first esophagectomy done in 1913, published in 1915. So just about 100 years of surgical history under our belt at this point. Dr. Tork in New York, pretty wild operation if you look at it. Left-sided thoracotomy, massive incision there. I think beautifully thought out and probably prescribed before the operation. The reconstruction a little interesting, almost looks like a garden hose hooking up there, that distal esophagus to stomach. Interestingly, this female patient, I think late 40s if I'm remembering correctly, survived, I believe, 7 years after this and passed away not from her cancer but from aspiration pneumonia. Operative techniques over time: Ivor Lewis, the 1940s, McGeown, 3-hole, 1970s, transhiatal, 78. And then really the jump into MIE, minimally invasive esophagectomy, and then RAM-E, or robotic assisted minimally invasive esophagectomy. And we'll look a little bit more into that now. So Ivor Lewis, distal 2/3 esophagectomy, historically laparotomy with the right-sided thoracotomy, a gastric pull-up. This is kind of what it looks like. All of these operations are really tubularizing the stomach. Critical anatomy to know here is your right gastroepiploic artery, right gastric if preservable. Perfusion of the conduit is probably the most important thing. My take on this: advantages, great for thoracic lymphatic dissection, easily translatable to an MIS or MIE approach. Disadvantages: limited resection, so you are not removing all the esophagus, and you do have inner thoracic anastomosis, so if it leaks, a little bit more risk of morbidity, mortality. This is definitely my choice of operation for tumors of the G junction, which we're discussing today, in distal esophagus. Risks: in hospital mortality somewhere between 0 and 4%, depending on what studies you look at, and it's comparable to the transhiatal esophagectomy or cervical anastomosis in regard to mortality. It does have a lower leak rate, the thoracic anastomosis, than the cervical anastomosis, most likely due to less tension, right? It's a shorter distance for the pull-up to go, and therefore shorter distance for the blood supply as well. Typical leak rate somewhere between 5-15%. Usually high volume centers are lower than that, 3 to 8%. Atrial fibrillation, 20%, and that's usually related just to pericardial kind of irritation, either during the time of surgery or where the conduit is. McKeown tri-incision esophagectomy. This is your classic left neck, right chest, and midline laparotomy, cervical anastomosis. Great for combo with VATS, chest, and the abdomen. Disadvantage: multiple operative fields. Again, my choice for either mid or upper tumors, large bulky tumors, or if you need a 3-field lymphatic dissection. Transhiatal esophagectomy, again, this is a cervical anastomosis. This is no thoracic incision. This is going to be a left neck incision and laparotomy. In-hospital mortality rate 1 to 4%. We said similar to Ivor-Lewis. Leak rate, again, a little bit higher due to that cervical anastomosis. Concerns, though, really, I think there was a dip in the number of these when we were doing more preoperative radiation. The scar tissue and planes were a little bit more challenging. Can't do the blunt dissection as easily. Really, that blunt dissection is critical down that prevertebral plane. So notice increased intrathoracic hemorrhage, intraoperative bleeding, risk of recurrent laryngeal nerve injury, and a chylothorax. So I only use this one really for benign disease, maybe strictures, things like that at this point. But I could see this making a comeback now that FLOT is our preferred chemotherapy agent. And there might be a dip here in the near future in the use of preoperative radiation. Okay, so what you came for: open versus MIE versus RAMI. Let's dive into a couple of these studies and see what we can tease out. So one of the first studies is the TIME trial. This really looked at MIE, minimally invasive esophagectomy, versus open, published in Lancet 2012. And it's, again, this is for Ivor-Lewis type esophagectomy. Really focusing on that abdominal and thoracic part that's being done in an MIE, minimally invasive approach, not robotic at this point. And we noted there's decrease in pulmonary infection, complications, lower ICU stay, but same oncological outcome. So R0 versus R0 resection and lymphatic resection. Next up is the Marrow trial. And what you'll see here is this is an MIE hybrid approach. So the abdominal part's done laparoscopically and the chest part's done still open, so open thoracotomy versus an open operation. This is 2019, published in New England Journal of Medicine. Again, this looks at Ivor-Lewis approach. So our patient population of distal adeno G junction tumors are in this study. And what we find here is even with a hybrid approach, decreased major complications by about half, 36% versus 64% in the open. Lower pulmonary complications, no difference in cancer outcomes. So 3-year overall survival on oncological outcomes. Jumping here to the Robot trial. So this is, again, RAMI versus now open transthoracic esophagectomy, Annals of Surgery, 2019. This, again, is going to be for our patient population, so adenocarcinoma, GE junction. And what do we find? Overall complications decreased in the RAMI, 60% versus 80%. Pulmonary complications, postoperative recovery better, oncologic outcomes similar. So all good news for MIE and RAMI versus open for the patient populations we've been talking about. Now we're going to go a little bit off script here. This is going to focus a little bit more on squamous cell tumors, but these are our first studies that actually go head-to-head comparing Robot versus MIE. So this is published in 2024, And now this is high volume centers out of China and Taiwan. So some critical information to know. Again, squamous cell, MIE versus robot. And for this is transhiatal approach. So again, 3-field lymphadenectomy, squamous cell cancer, not really what we're talking about today, which is GE junction adeno. But you notice that they got better lymph node dissection and safer for recurrent laryngeal nerve injury. So this is where precision starts coming into play when we look at robotics. Little brand new study 2026. So this is Ramey versus conventional thoracic MIE. Again, this is out of China and very particular in squamous cell cancer. So again, not what we're talking about today, but this is the first study that showed, okay, lower operative times. That's great for Ramey, but overall survival, Ramey at about 70%, with the MIE at 55%. That was statistically significant. So could there be actual survival improvements in the operations that we're offering? Okay. Come back a little. Okay, so some registry data. This is back to our patient population: Ivor-Lewis, adenocarcinoma, GE junction, leak rate evaluation, really safety. But again, this is not a randomized control trial. This is just looking at survival. At clinical outcomes versus registry data. Really, what we need is what is up next is the Robot 2 trial. So this will be a randomized controlled trial comparing Ramey to MIS for adenocarcinoma at the GE junction. This should give us our much more insight into the value of robotic surgery versus MIE. And I think we'll see similar things to what we saw in squamous cell. So what do we know? Pulmonary complications decreased in MIE and Ramey, length of stay shorter, MIE Ramey, pain decreased in MIE and Ramey. Lymph nodes equivocal, same lymph node resection, maybe a little bit improved in Ramey in that 3-field. R0 resection equivocal, technical precision probably increased in Ramey. All right, leak rates, one of the feared things in any sort of esophageal resection. Historic mortality from a leak rate was about a flip of a coin. Death 43%, current mortality rate 3.3. What has happened? Earlier enteral feeds, flat protection, omental muscle, ERAS protocols, enhanced recovery after surgery, and leak management. I think this is the most critical area where we now have endovac and a better understanding of esophageal stents and when to use these devices. Modern era, there's no difference in mortality and leak rate. So 3.3 versus 2.5%. Stents, great for contained leaks. When we got good granulation tissue, things are healing. Our option at our center is usually quick to endovac placement. Excellent cleaning out the wound. And we'll usually do 2 to 3 of these treatments, and if needed, place a stent over it, or if it's a contained leak, continue the patient MPO with tube feeds. Okay, complexity of surgery. I believe this was published by one of our speakers. These are challenging cases. Got to know the anatomy, surgical plane, steps of the procedure. They put them at level 3 operations. Again, another article published by one of our speakers from earlier. Learning curve somewhere between 120 and 20 cases. But with a developed structured program, maybe 20 cases. What does that look like? We have to have a basic understanding of esophageal surgery and MIS. Some way there needs to be some sort of proctoring, though. So case observation in a high volume center, understand robotic surgery and go to a course, cadaver lab. But proctoring your first 3 to 10 cases, that's a lot of proctoring, especially if you're not at the same institute. So what could this look like? I would suggest there are online platforms now. Surgeon I'm very involved with. We host Foregut channel. I believe the next one we're going to actually go over esophagectomy May 12th. It's free for any physician or surgeon to participate in. Just sign in. AIS is another great channel with great content on it. I'm a big believer in teleteaching and teleproctoring. This is where we learn by sharing best practices and helping coach online. Written 2 articles on this. This is very different than telesurgery, which is surgery in a different or remote area. So how can we do this in a safe manner by teaching across essentially the world? I encourage you to read these articles if you're interested, and I am always available for any sort of teleteaching or telecoaching. In conclusion, all right, EG junction, adenocarcinoma. We know now that FLOT is the preferred preoperative treatment with chemotherapy. Secondary to the ESOPEC trial. Surgery, MIE over open approach. My theory or thought is that the Robot 2 is going to show us very similar to what we found in squamous cell, that Ramey will give us greater precision. For lymphatic dissection, two-field approach for GE junction tumors is just fine. We do not need to do the cervical dissection. Early stage cancer, T1A, either directly to surgery or consider endoscopic resection. We can do another discussion on that. And post-operative complications, endoscopic salvage with endovac and stent has been a game changer in decreasing mortality rate around this surgery. Again, I want to thank the speakers, the society for the invitation. This has been a true pleasure. This is my direct email at the University of South Florida. Feel free to reach out anytime with questions or if you'd like to connect. Again, teleteaching or telepresence, happy to participate in any way possible. Thank you very much. And this is a challenging patient population to take care of, a true passion of ours. And I think the only way we're going to really beat this is with the advancement of our chemotherapy agents and our early detection and screening, so we can treat this more with endoscopic approaches. And hopefully we look back one day on esophagectomy as a historic operation. Thank you.